Well, I'm going to jump in and start our welcome and get us going today. And I know people are going to be filtering in. So I just want to welcome everyone to the first of the 2024 research rounds. I'm Catherine Donnelly, for those of you who I haven't met or haven't joined us before, and I'm the Director of the Health Services and Policy Research Institute here at Queen's. It's nice to be back to another year, and we'll be having monthly rounds, as well as we're also started a new series last year called Methods Mondays, which starting in October will be the last Monday of each month. So we'll dig into some methods in health services. Just to let everyone know that it will be recorded and gets posted on our HSPRI YouTube channel, so you can take a look at this and others. And actually, Joan has done a previous webinar before, so you can see some other of her work. So I just wanted to start today by recognizing that those of us attending from the Kingston area are situated on the Anishinaabe and Haudenosaunee territories. And as many of you know, yesterday was the National Day for Truth and Reconciliation. And as a reminder, it's a day set aside to honor the children who never returned home and the survivors of residential schools, as well as their families and communities. And yesterday, many of you might have been able to attend the number of events both here at Queen's, Kingston, and nationally that were recorded. And it was a chance for me to reflect as well. And I went back to the 2015 Truth and Reconciliation Commission report. It's hard to believe it's been almost a decade. And reminder, they had 94 calls to action. And number 23, I thought was really important to think about today. It reflected specifically on the health workforce, which Dr. Almost will be talking to today. And the report calls upon all levels of government to increase the numbers of Indigenous professionals working in healthcare, increase and ensure the retention of Indigenous healthcare providers in Indigenous communities, and provide cultural competence training for all healthcare professionals. So as we're here today to listen to Dr. Almost, just consider how health systems and policy research, and specifically work looking at health workforce planning and retention, can support principles of equity, diversity, and the calls from the TRC. But I am very pleased today to introduce Dr. Joan Almost. Joan is a professor at the School of Nursing here at Queen's University. Her research broadly explores health workforce, and more specifically nursing leadership, practice environments, and nursing and work relationships. And we are very lucky to have her today, hot off the many different events she's been speaking to news about. The report she's here to talk to today. So again, hot off the press is based on work she's conducted with the Canadian Federation of Nursing Unions. Their report explores the use of for-profit agencies across Canada. And Joan, we're really excited to hear you dive deeper into some of the methods and the findings that you've had. And I know you've been talking to lots of different media, and which we'll put some of those links in the chat. So I'll pass it over to you.
Great, and thank you, Catherine, for first inviting me, and HSPRI for welcoming me so quickly after the report was released last week to come and talk about this very interesting topic. I'd also like to definitely acknowledge the funding that was provided by the Canadian Federation of Nurses Unions. They had put out a request for proposals, I guess, early last year, and I jumped at the opportunity, not really knowing how much work was ahead of me, but was very fortunate to have the chance to work with them, because obviously without the research, this work would not be done. Also like to acknowledge the research team here at Queen's. Again, without them, this work would not have been done. They worked diligently with me for the last year and a bit to get through not only just the data collection, but also the many barriers and barricades we had along the way, and trying to problem solve ways around it so that we could get as much data as possible. So I want to start off just by, first of all, defining what's meant by private nursing agencies in the report. So our focus really was on the for-profit staffing companies that provide what's usually referred to in Canada as travel, temporary, or agency nurses. And that's really been the focus, is the actual agencies in this report. So the agency tends to hire the nurse, arranges contract with facilities such as hospitals, long-term care homes, that typically span anywhere from a few weeks to several months, and then arranges for nurses to fill those contracts. The agency is then paid by the facility based on the terms outlined in the contract, and in turn, it's the agency that pays the nurse. So it's a very different relationship than what we normally see with a nurse working in a hospital. However, the nurses are then supervised and work under the direction of the facility where they are working, but they still are ultimately are paid by the agency and report back to the agency who monitors what they do. So why do we do this? So, agencies are not new. They've been around for decades and have been a very important part of the healthcare system for many years. But they originally were really filling short-term staffing needs in rural remote settings, and also, some within hospitals, critical care areas where, staffing was short and was needed. But the number of nurses that was working for them was always believed to be rather low, and they were very restricted on the areas that they were working. So it wasn't tended to be a big, what was perceived as a big problem. But of course, with, even before the pandemic, I mean, nursing job vacancies were already growing each year. And then when the pandemic hit, the floodgates just opened. With a parallel rise, obviously, in the use of agencies to fill critical staffing needs, limit service cuts, and to keep facilities open. And unfortunately, that trend has continued, which is what is really the concerning part of all of this. And media reports for the last few years, if any of you read, think articles in the Globe and Mail, Toronto Star, CBC, certainly across the country have painted a stark and alarming picture of how public money from the public healthcare system is being spent on private for-profit agencies. However, beyond the media reports, very little is actually known about the use of agencies across Canada. So there was definitely a gap looking at this from a national perspective, as well as some of the local, each of the jurisdictions. So CFNU again would become very interested in this because they were hearing a lot about the stories, and that was really that kind of the impetus of what was behind the work. So the purpose was a very general purpose, was just to examine the high use of private for-profit agencies across Canada. More specifically, the objectives were, what's the current landscape on the use of agencies? So how many agencies are there? What's the cost associated with them? How many hours are they being used, and where are they predominantly working? And then the second objective was to kind of step back and, okay, I'll get, collect different perspectives on what's the actual impact of agencies on things like human health, human resources, privatization of the public healthcare system, and the retention and recruitment of the nursing workforce. So the study started off, with these what might seem like simple purpose and objectives, and it certainly grew as the time went on, because we realized there was so much more we could be looking at. So we ended up with 18 research questions to guide the study, and that's, if any of you have seen the report, that's sort of how the results have been set up, is based to answer each of those research questions. So we did use a mixed methods data collection process. A variety of primary and secondary sources were identified, and we tried to obtain them across Canada. And this is where the study became very, very complex, because it was challenging to find data that facilities and governments were willing to share with us. So we started off with a scoping review. So we only found one Canadian article, and that was found late in the process. The rest were all international articles. We put out a request to the nursing regulators across Canada, asking if they know how many of their nurses that are members in their organization actually work for agencies. Only 6 of 11 responded, and they all said they didn't have data. And one within Ontario actually did have data that was publicly available on their website. We contacted Hi for access to their database for the last, for 4 years. To see if they had numbers of nurses that were working for agencies, and they do, because it's based on what the regulators provide. But the numbers were quite low compared to what we were hearing from certain facilities. So that number doesn't seem to have caught up with the actual reality of how many nurses are working for agencies. And then we did online survey to chief nurse executives, predominantly in the health authorities in the provinces and territories. And then to majority of the hospitals in Ontario. We couldn't go to every last facility in Canada because of time. So we didn't go to long-term care in Ontario, but we did do hospitals. So you can see only 33 out of the 141 responded. 16 reported they used agencies, 15 reported they'd never used agencies, and 1 declined, and 1 referred us right straight to the access to information request, which was our next step after we got low response to the surveys, was then, went back to the health authorities who didn't respond to our survey, and gave them more formal access to information requests. So 11 of the 19 responded with varying degrees of data. 2 indicated they didn't have data. 2 actually asked for a very high cost for us to to obtain the data because they felt it was going to require a great deal of time. So we unfortunately weren't able to pay the costs that they had asked us to pay because of the funding budget. And we also put then a request out to provincial nursing units to see if they had had any recent access to information requests. So 9 of the ones that were contacted, 7 of them were able to give us additional information, which was very helpful and helped fill in some of the gaps that we were missing. And then to kind of go to objective number 2, where we're looking for perspectives, we then started to look at, okay, the various groups that might be affected by this. So we looked at online surveys to nurses, managers, and students. So we had 592 nurses who actually currently work with or previously worked with an agency in Canada within the past 5 years. We then asked, we had nurses and managers who work in facilities that use agencies were asked to complete a survey, and we had a good response to that. And then we also asked nursing students who were in their last year of the program about the use of agencies and whether they're interested in doing it. So we had a few answer that survey. And then we delved deeper with some of these groups into interviews. And so again, went back to nurses who work with or previously with agencies to get their voice and their experience. And then we interviewed employers who use or don't use agencies. So these were predominantly chief nurse executives, but we did have some directors and managers as well. And then we also interviewed 6 nursing leaders from across Canada. And the data analysis was really descriptive with qualitative content analysis. So key findings, I'm just going to walk through some of the key findings. If the report is quite lengthy, the body of the report's almost 100 pages. And then if you add all the appendices, it's closer to 200. So there's a lot of information in there. I'd need probably 3 or 4 hours to get through it all, which would put, it's too much. So I'm just going to touch a bit on each of the aspects or most of the key points. And then hopefully we'll open up for questions and discussion for the last half of today's rounds. So the first one was, how many agencies are there? Tricky question because it's how you define it and so forth. So we use the data that we obtained from the chief nurse executives and from the access to information requests, as well as we asked nurses who were working with agencies where they were working. So from those different sources, as well as some media reports, I guess, so some places had, other ones that they identified. So those 4 sources, showed us there's actually 472 agencies identified across Canada. Certainly it's not all inclusive and doesn't differentiate between types of agencies. So we are not able to necessarily tell which ones are for profit and which ones aren't. But this is where, the nurses that are working with agencies are coming from. Excuse me. The numbers used by actual facilities really varies. Some of them, but most of them reported increasing the numbers over the last 4 years. Our focus was really on the 4 years from 2020 to 2024 were our main areas, but some had data before that. As I mentioned before, we had 15 chief nurse executives say that they've never used agencies, so 14 were hospitals in Ontario and 1 health authority in another province. And 3 health authorities in Quebec reported the highest numbers, with one ranging from 249 to 262, which I just think the amount of work that it must take to organize 249 to 262 contracts must be overwhelming. So then we looked at, what's the cost? And we asked, again, different sources, so predominantly the employers, but some of this was also obtained from the media reports or Auditor General reports. So you can see the numbers have grown from 248 million up to 1.5 billion. Sorry, I need a drink. That's a 6-fold increase in just 4 years. And the concerning part is that the number is still going up every year. And the more concerning part is that number actually is an underestimate. Sorry. We didn't get data from every, obviously, jurisdiction. We did our best, but it was very underestimated. So it's probably a lot higher than that. Sorry. So it's very concerning that much money is being taken from the public health system and put into private profit agencies. Think what could be done within our public system with $1.5 billion and more. We also found some contracts on the federal government site that looked at listed all the contracts for the last 5 years, and they've spent $3.2 billion. Sorry, different agencies, governments. Sorry, different government ministries or departments on agencies. So if we add that in right there, we're looking at, easily $2 billion. So the numbers are quite shocking. And like I said, the number is shocking because it's still going up every year. We then also asked, how many hours are being spent or being used by agencies. And again, you can see the numbers been going up every year. Even now, if we consider we're past the height of the pandemic, we're still increasing our numbers. So it's 7.3 million, and that's it's equivalent to just over 3,000 full-time equivalent jobs, which is a lot. RNs are the most that are most frequently used. LPNs are next. Registered psychiatric nurses are used a little bit, but certainly not as much. And then NPs are probably used a fair bit as well, but not as much as RNs and LPNs. So again, numbers are shocking. That again, it's significant jumps every year. Which sectors and settings are they being used? Predominantly, what's been reported by employers is long-term care, critical care units, emergency departments, medical units, and then after that was really a variety of different areas, but predominantly acute care. Rural and remote was also an area that was identified as key. It didn't come up in the most frequently reported, but I think it's also where they're being used quite a bit. Then we looked at, how much are agencies and how much are they costing, like by the hour? Because that's often the big question is how much are they charging? And so we asked the employers to identify how much they're paying to agencies per hour. So interestingly, what I found, that the rates actually rose moving from the West Coast to the East Coast. So the East Coast had higher costs associated with how much they're paying per hour. The lowest rate was in Manitoba at $65 an hour, which Manitoba the government has put in legislation to set the hourly cost, as has BC. But the highest was out in Newfoundland and Labrador, which isn't surprising given some of the media reports around what's happening in Newfoundland and Labrador as well as New Brunswick. So they were over $300 per hour of what they're being charged. And then there was a wide range of the costs, the hourly costs across facilities. So you can see in Ontario, like for the cost for a general RN was anywhere from $53 an hour to $260 an hour. So that's the same province. Different agencies are charging different costs. And especially RNs are anywhere from $81 to $195 an hour. So those are the groups that are working in the ICUs and the emergency departments. And then for the LPNs, similar trends. Manitoba was the lowest. The highest was in New Brunswick at $306 an hour. And then, wide ranges across different health authorities as well. So, it's hard. It's still a moving target about what agencies are still, charging. It seems to be they have a wide range of what they can charge. The one, and I'll show a slide in a minute about what other factors are part of these costs. It's not just, what's being paid to the nurse, is what's being paid to the agency for other costs. But we also then asked the nurses that responded to our survey that are working with agencies, what are they being paid by the agency? So again, you can see a wide range, anywhere from $39 an hour to $300 an hour, with an average of $71 an hour. But it really varied across settings. Hospitals, not surprisingly, were being paid more than some of the other sectors, such as long-term care and community. 40% said that they worked for more than one agency, and they said that even when they were doing that, they were being paid different rates, ranging from $2 an hour difference to $74 an hour difference. And that was really based on, the agency, what province and territory they were working in, and where in the province they were working. So northern locations were being paid more. So some of the examples that some of the nurses provided were, the wages in BC were $55 to $62 an hour, New Brunswick was 90 to 110, and then Ontario was kind of in between. And then wages, working in ED would be higher than working in long-term care. And then, as I mentioned, there's several factors that affect what these costs are. Again, the agencies seem to be able to, ask for extra items that would be covered, such as the most frequent, direct costs for paying for the nurses' travel, either within their role. So if they were traveling in the community between clients' homes, they were paid for that and for gas, versus travel, location costs. So if they were, having to travel from Toronto out to Vancouver to work there, their travel costs were all covered by the healthcare facility. Then their accommodations are being paid for, per diems for meals, other costs like that. And then if they're, especially areas, they're being paid more. And then certainly, indirect costs on, onboarding, orientation, identification badges, all those things to start working in the organization were, being covered by the healthcare facility for the most part. So most of these, again, we're all being covered by the facility, not by the agency. And may have been part of the hourly costs and may not have been. And then what nurses themselves have said, what they're paying, the extras that they're being paid for, is again, travel costs, accommodations. Some have their parking at the facility paid for, and per diem meals. Some talked about, they'd have their registration fees if they were moving to a different province covered, if they worked a set number of hours. And then they'd also receive double overtime if they work so many hours in a 28-day period. So again, it really varied. There wasn't a lot of consistency, except for Manitoba and BC, which they have set rates, but even those provinces still have extremely high costs of what they're paying overall. So it's still, and I've had a lot of media ask me, okay, so how much are nurses making? Well, there's no one answer. It really is unknown, because there's no consistency and there's no oversight of what these contracts are. So then, in our survey with the nurses that are choosing to work with agencies, we asked them questions about, why are they working with agencies? We found the younger age groups were more likely to consider working with an agency, which, not surprising. And then 74% of the students who were surveyed, were considering working with agencies in the future. Most frequent reasons that they want to do this is, better pay, including a chance to, make more money with overtime, choice of time off, more flexible work hours, seeing, new towns, facilities, different practice settings. Students also identified housing and/or food allowances as some of the more frequent reasons. But the main reasons, when they were asked to identify what's the main reason, better pay, work-life balance, schedules, and flexibility. Flexibility came up, and I say across the study, that this was one of the main reasons, besides pay, that they want to work with travel agencies or private agencies, is because they control their work life. They can control how much, how long the contract is. They can control where they're going to work. So if they don't like one place to work there, they don't go back there. And it just gives them a lot more control over what they're doing. 92% said that they worked in the public system prior to working with the agency. 57 didn't resign. They continued on working for both. And 87% did not return to the same facility to work as an agency nurse. And we asked that question because there's a lot in the media about how, they probably leave an organization and they come back and make double the wage to work as a nurse with an agency, and that wasn't the case in this survey. 68% worked for both an agency and the public system simultaneously. And then you can start seeing, some of them worked for the same facility for 1 to 3 months, 20% were 4 weeks or less. So that's 50% that, only worked in the same place for anywhere from 1 month to 3 months. So short-term contracts, a lot of turnover. 87% said they were scheduled in the same practice area consistently. And 83% said they had a choice of where they worked. We asked them about orientation. So 87% said they did receive some type of orientation. It varied. And, it ranged anywhere from 2 hours up to 3 days. So some received no orientation. It was sort of like you showed up just before the shift started, so you could, show yourself around, and then you were on your own. So again, that really varied by facility. Advantages of working with an agency, is very similar to the reasons why they've chosen to go into it. So, higher pay. A lot of them talked about, avoiding workplace politics and the administrative burden. They could go in and do their job. They didn't have to get involved with all the other stuff that went on in the unit and then go home. They have opportunities to network. They, met a lot of friends traveling and getting to know new people, the flexibility, new experiences, and different opportunities. A lot of them did describe disadvantages, it's uncertainty of where they were going to work, concerns if they were putting their license at risk because of knowing that they're new to an area, as well as they felt they were going into some unsafe practice areas, being isolated, being in a new city that they didn't know anybody, no benefits when they were working, so they wouldn't receive pension or medical coverage, or et cetera. And also they're very clear. They felt that the media their portrayal of the media is very negative, and they're getting very frustrated with that. And then we asked them what's the impact of working with an agency, and really overall it was quite positive. Personally, most of them were very happy. Obviously, they're making higher wages, have a much more control over their work life. But some did report that there were changes in their relationships with their colleagues and friends because they didn't like the fact that they were working for an agency and making a lot more money than them. Professionally, they felt it really gave them a lot of opportunity to push or test their own limits, so they improved their team working ability, adaptability, professional growth, and really, helping them focus on understanding their scope of practice even better. So very positive. And then patient care, again, the large majority, probably the range was in the 80% range, really felt that, that nurses welcomed them. The units felt that they were, having extra staff gave them a chance to provide better quality care. And they went to work feeling fresh because they had time off and vacation. And they did identified that being placed in the same facility or unit for a longer period would actually help promote continuity of care. So they said a lot of agencies tried to do that. But in the interviews, the nurses did talk about how they could see how the short-term contracts and the constant turnover could certainly have a negative effect on the care being provided. Some survey participants did also say though, that they felt a lack of support in the facility. They felt very alone, that they were an outsider coming into a team. They were less assertive because of that. They were treated differently, that they really had to earn the team's trust by demonstrating their competence. And they felt a lot of pressure to perform because of their wage discrepancy or the perception of agencies. Interview participants, they identified that they didn't feel the role was appropriate for new grads. They felt new grads needed the experience at a constant setting for a longer period before they started doing agency work, so that they understood their scope of practice. And they could, also identify that it may not always be the nurses may not always be placed in the best areas, either due to the lack of experience in that specialty or language barriers. So they talked about how sometimes, nurses that are English speaking would be placed in a hospital that's only French speaking and everything's in French, and how that could be unsafe. Then we asked, what are the experiences of managers and nurses working in facilities that use agencies? So the majority, reported working with nurses from agencies on a daily basis or 1 to 2 times a week, with an average of about an hour spent each shift, which was probably low because some nurses reported 0, as you can see on the screen, that they didn't work with them a lot. And that was because they'd had agency nurses previously, but not currently. So they reported current as 0, but really they'd had them previously. Advantages, of having agencies is, fills vacancies and all the benefits of that because it improves the nurse-patient ratio. They found the nurses that were coming in with lots of experience were very knowledgeable, were willing to work, pick up last-minute shifts. It helped decrease overtime and have vacation time approved and improved mental health and prevented, cancellation of services. The disadvantages, and this came through very clearly in the surveys, is that strong sense of loss of unit values and culture. That, the nurses coming in were new, they were there for such a short time with their short contracts, and they didn't really value who the unit was and what they did. And it was almost like a sense of community. It was lost within the unit because of that constant turnover and the loss of a consistent team. Where there was no longer working with familiar faces or people they knew and trusted. And we all know within healthcare, the team's a big part of what we do. and who we work with is very important for our own mental health, but also for patient care. And that came through as that was really lost. You know, nurses are being dropped in for short periods of time, and then they're gone, and they start all over again. Um, and they were frustrated because there was little or inadequate orientation being provided by the facility, or a lot of times what would happen is the new nurse would be buddied with a permanent nurse, and the permanent nurse would have to do the orientation basically. So they were getting frustrated, and that increased the workload of the permanent nurses. So impact on patient safety, teamwork, and continuity of care really ranged, and really a lot of them identified, really varied depending on the experience of the nurses from the agencies. If the nurse was experienced and was a great team member, it worked really well. When they weren't, it didn't work so well. But again, the short contracts and the constant turnover really impacted team dynamics, workplace culture, the workload of permanent nurses and managers. They're expected to provide orientation, ensuring the protocols were followed, answering questions to make sure they understood what the protocols were, where the resources were, who the patients are, and then having to do extra work to make sure that all the other work that maintained the overall unit function that may not be part of patient care, but with making sure the unit function fell back on the permanent nurses. And then of course managers, an increased workload because they had to help make sure orientation was done, go through all the onboarding, and so forth. And then continuity of care, I think, is the one area that stood out as that there was huge implications around the continuity of care because of the short-term contracts. So, their lack of familiarity with patients, resources, policies, routines, charting requirements, everything like that, is missing because, they get familiar with how to do it. If they're there for 3 months, then they're gone. But if they're only there for a month, it's hard to do that. Long-term care residents, especially, the lack of familiarity was leading to increased confusion and aggression. They want to be able to see the same faces, every day and not have new people all the time. And then the anticipation of long-term patient issues was also missed. It's great to come in and do, patient care for, 12-hour shifts, but it's having that vision for the future of how that patient might be in a week. And if you're not there that long because of the contract, it's hard to do that. And then permanent nurses feel very disrespected and devalued because of the wage disparity. Imagine doing your job and working next to someone who's doing the exact same job or less, because they don't have the knowledge of the units, but they're being paid a lot more than you, and having their accommodations paid for and their meals paid for. They felt very disrespected by that, and also the lack of recognition by their employer because they actually stayed. There's no retention bonuses. And then also they were having their shifts and their hours altered or being asked to go to other units, because the nurses coming in from the agencies couldn't do that. So then we interviewed employers who use agencies, and the main reasons that they use them is I think pretty obvious. Is they're unable to fill vacancies or recruit and retain nurses. They feel obligated to fulfill service obligations and remain open. But a lot of them talked about that tension between that balancing fiscal responsibility and keeping the doors open. And talked about they had to have a lot of conversations because agencies would increase their hourly costs, and how to when do you say enough's enough, especially when if you say that, then the nurses are going to be working short on this in the units or in the community, and that you might have to close your emergency department for the weekend or longer, or cut back on services. So they talked a lot about that. Other participants also identified that employers have used poor retention strategies, and that's why nurses are leaving. Nurses are not being listened to. That there was a huge underestimate of nurses leaving, that they didn't believe they'd actually leave, and that there's a big shift in the demographics of our nursing workforce. The new generation's not going to work the same way as the older generations, and I think now that they have the alternative of an agency, that's become quite clear. And then impact of agencies in a facility. So there was a really destabilizing effect or the erosion of relationships within teams. was also discussed by employers, that they saw that within the team. Extra workload for everybody. And they talked about a vulnerability in the system. So they talked about that they, as employers, they don't have the same ability to maintain quality management by overseeing or following up with nurses from agencies when a clinical practice concerns raised. And that was a big concern that they were raised. So if a nurse was having a clinical practice concern and they were from an agency, they would have to report it to the agency, but they didn't know what the agency's process was, and it was no closing of that loop. So they don't know if it was actually reported to the regulator, if it was appropriate to do so or not. So they were concerned about that. So I mean, they could certainly not invite that nurse back or that agency back, but that didn't solve their concern about what happened afterwards. And rural remote settings are certainly have been really deeply affected by this, because they were the ones that were having agencies previously, and now with urban sites relying more on agencies, it's increased their challenges significantly, because they're having even harder time having staff in their areas. And then we asked nurse leaders about what's the impact on the public health care system overall, and this is the list that they talked about. So, again, disruption of the public system, exploitation of the public healthcare money, lack of transparency, oversight, and accountability. And that certainly has come through in a fair number of the media reports that have been reported, especially out in New Brunswick and Newfoundland. Also, some of the contracts and clauses, some of the agencies have clauses in the contracts that nurses that have worked with them can't go back into the public system for anywhere from 1 year to 2 years after they've left within that province. They can go to another province. So it's not helping that province, recruit people if they have these clauses in their contracts. I've talked about the impact on rural and remote. Also, the negative portrayal of nurses working with agencies is very much a concern, that it feels like nurses themselves are being blamed for this situation, when really it's a structural systemic issue, and that's at the root of the problem. And that's what we need to be addressing, is not the nurses. Who can blame the nurses for going someplace where they have a better work life and more money? It's looking at, why are they leaving, and figuring out ways to solve that. And then, it's eroding the public confidence in the nursing profession and the public healthcare system. So it's that notion again, nurses are just plugging holes. They're just being dropped into places and instead of, being valued healthcare team members. And then I think, the realization that many are leaving our profession and the public system because of the conditions. And it's just not sustainable as it is currently. So there's 3 recommendations, and we kept them short, and these are very high level recommendations, and they are really meant to be a group, not individual ones. So the first one is we need to work at phasing out the use of private for-profit agencies. And this isn't something that's going to happen overnight. I mean, there's no way, and that's not what we're suggesting. This is something where employers and governments need to develop a plan. How are we going to stop our dependency on agencies? Because, think about $1.5 billion is being spent last year, and that was projected. It's probably a lot higher. We can't keep doing that. And we can't, because the costs are going to keep going up. So, how do we phase those out? And there needs to be plans. And we also need to find an alternative. The governments, like Manitoba and BC, have both put in place provincial agencies that are under the public system, the public government, that are predominantly for the rural remote settings, but they have moved into like Winnipeg and so forth, where the nurses have similar ability to be flexible. They get paid more. They have a chance for bonuses if they work so many hours. So they have kind of that, similar work-life balance and so forth, but they're under the public system. And they seem to be working. I mean, they've taken a while to get up and running and to get the nurses to start going into them, but they are showing signs of flexibility. I actually had a nurse email me. I sent out a report to the participants who wanted copies of the results, and who responded and asked me if I knew about the one in BC, and that she works for it and she loves it. She said it gives her flexibility, and it's just so much nicer than working in the other system. So there is that possibility, and that's what needs to be done, is give employers an alternative. I mean, the nursing shortage isn't going to go away overnight either. And that's the recommendation is, you know, we need to start addressing it more effectively. Some provinces are doing it, others not so much. And, you know, retention is big. You know, Health Canada put out a work retention toolkit earlier this year that has lots of evidence informed ideas, and that needs to be utilized more. And we need to find a way to keep the nurses in the public system or bring them back. Recruitment's also important. Obviously, we need to increase the numbers, but that's not the only solution. And then until all this can happen, we need to find ways to, you know, implement regulations and oversight. Government needs to have some control over these contracts. And again, some provinces are doing that, not all. You know, they need to be registered businesses. They need to have their how much they can charge regulated. And there needs to be something to try to keep the costs lower than they already are. So conclusion is, you know, the use and the costs of agencies, you know, is rising well before the pandemic. It ballooned during the peak years of the pandemic, and it's still a growing concern, as the numbers in the studies have shown. The use of agencies is certainly advantageous with the additional staff fill of vacancies, but that's just a band-aid. It's not a solution. It's a band-aid for a problem. And we need to stop relying on that as a band-aid and start finding some actual solutions that can be used in the public healthcare system. And then due to, you know, the transient nature of the agency contracts, there really is a destabilizing effect on healthcare teams. The workload for permanent nurses is increasing, and the continuity of care is a concern. So it's really disrupting the public system, destabilizing the nursing workforce at a critical time where we don't need to be destabilized any further. And basically, you know, our healthcare system and the nursing profession can't continue down this road because these costs are just not sustainable over time. So thank you. I'll open up for questions.
Thank you, Joan. That was excellent. I felt like I was giving you my cold over the Zoom
I
there.
know.
Oh dear, I jinxed her. I have literally been writing notes the whole time. I had taken a look at the synopsis report, which is excellent, really impressive work. And so I have a number of questions I would love to ask you, but I know many people here probably have the same. So if people want to pop questions in the chat, if they want to raise their hand, unmute, I'll sort of open it up right now. Sherry's also been putting some links in. So there's the link to the report as well as the toolkit. Katie.
Thanks, Joan. That was like incredible work and so timely and relevant. So thank you for doing this and putting so much of your time into it and sharing this because it's so nice to see a thorough, rigorous academic report come out of this very important current issue that's affecting our whole profession. I would like to ask, I'm just curious, I notice, so I'm not a practicing RN right now, but I have a lot of graduate students who are and friends. And why, like I realize that you're speaking to your data, but why can't hospitals just treat RNs better? Like why can't they, why can not funds be diverted to increase the RNs that are permanently rostered at facilities? Or another thing I hear a lot about is my students have every vacation request declined that they put in. Like, why are we not working towards improving the working conditions for working professionals in here? Like, I was just wondering if you have any thoughts on that.
Well, I think that's $1 million question, you know, Kate. And I think if we could have, if I had the answer, we'd be rich. You know, because I think it's it's not just RNs, right? I mean, this study looked at you know, all designations of nurses, right? So it's all groups. So I think you know, and if you look at my full report, we did ask a lot of the employers what they've been doing, and there's certainly lots in there around strategies that they've put in place. So, you know, some organizations, I think every organization is doing something. Why it isn't working, it's hard to tell. I think nurses are just, it's not, you know, in a lot of workplaces are really frustrated because they don't feel like they're being heard is a big one. So I don't have an answer. I think it really, it's an organization by organization strategy of what they're doing. And I think they just need to keep trying new perspectives. You know, we talked to 2 employers that had never used agencies. They did our interviews. And, what they talked about was just the fact that they poured money into the nurses that they have. So instead of, pouring money into the agencies, they poured the money into increasing the education budget. They looked at different ways the nurses, the teams work together. So they increased the LPN scope of practice, so that took some of the workload off the RNs. And there's so much that could be done, but it all takes time and it all takes effort. So I think some of it, is just because it does take so much time and effort that they don't have that time to do it because they're putting on a lot of other fires as well. So it is a challenging question. I mean, we've been trying to solve that problem for the last 20 years.
Thanks for your thoughts.
Thanks for that question. There's Roger, you've had a few great points in the chat. I don't know if you want to comment on them, or I'm happy to read them out. And then the next question by Dr. Chris Simpson.
Yeah, I can summarize them. Thanks, Joan. This is really amazing work, and you're a rock star. Just in terms of, my question really is there a correlation between, areas like Quebec? Because I think Quebec is one of the provinces where the hourly rate of pay is one of the lowest in the country. It may not be the lowest, but are these areas, and maybe you didn't look at this, but are these the areas that are more likely to rely on agency nurses because they pay so poorly to begin with that it's almost like they're creating their own problem? I guess that's my question.
Yeah, no, it's a good point, because you're right. Quebec does have by far the lowest hourly rate for nurses. I mean, their collective agreements show that, and they are the province that has the highest number of agencies. So they've had agencies forever, and you can see by some of the numbers I showed you. One health authority has over 250 agencies that they're working with. So I think it definitely makes a difference. I mean, Quebec has done other things I think that has really frustrated the nurses, and they're also the province that is I think working the hardest to try to remove the dependency on agencies, but they're doing it much more an aggressive way, like trying to ban them and and cutting nurses' salaries with them and so forth, which it doesn't seem to be working very well.
Can I ask the follow-up question? Because this question, my second question, came from your interview on the Current, and I remember at one point when you were asked about, there's almost the interviewer was incensed that a nurse could be paid $300 an hour, and I remember you responded to that. But I guess my question is, do the amounts that you've reported on include the percentage or the cut that the agencies get on an hourly rate, and what is that? And does that vary across the board as well? Like, is it a percentage of the hourly rate? Is it like an amount? How does that work?
That's a great question. I don't have the answer because we didn't ask that, and I honestly don't know. I don't know if the nurses would know, and I don't know if the employers would know that information. And I honestly, I'm not sure how transparent that is. I mean, and we didn't do side-by-side comparison about, this employer pays this and this nurse works at that employer, and like that would probably be the best way to find that out. But that's a different study.
Yeah, because the actual cost is even higher than what you reported, and that's some of the costs that I think you referred to, right? This is just the tip of the iceberg, right?
Yeah, and again, it's really it's the cost is unknown because some of those costs that were provided by employers would probably include their costs associated with accommodations and travel and all those extras, and others probably the baseline cost of that's just the salary. So,
Joan, I see Chris Simpson has a comment in the chat, and I know you've done quite a bit of other work with regards to retention and recruitment, just a reflection on the power of culture in maintaining workforce. And I don't know, no pressure, Dr. Simpson, to come off camera, but I don't know if you wanted to reflect on that, Joan. Oh, hi, Chris.
well, flexibility is the one there, and I think Chris, that's exactly it. It's flexibility. Nurses want flexibility. They're tired of the rigid schedules. They're tired of the rigid, in some ways even rigid benefits. Like that came up. Like, why does it have to be one for all, and why and not have options of different types of benefits and so forth, or pensions and so forth. So it's flexibility across the board, and I think that's it came through, and it probably comes through more in the full report than I talked about today about what are some ways to build that flexibility into it, you know, ability to self-schedule, ability to choose their benefits and their options that they do so, and choice of, you know, variety. And how do you, and the challenge is, how do you do that and still have, you know, have the the organization function properly? But I think the whole thing needs to be blown up. Like, I think even collective agreements need to be relooked at and build that in, because sometimes they're the barrier.
Chris, do you have another thought?
Yeah, just to build on that, Joan, first of all, really enjoyed your work as always in this area. And I think, you know, we sort of got into a bit of a vicious circle in the pandemic, because the shorter we got on resources, the more you know, rigid we had to be about things like you know, the shifts that we needed people to work. And the workforce, and particularly nurses, I think really felt this fundamentally as, you know, disrespectful and abusive, even, I would say. And but you know, in Ontario, at least over the last 8 months, we've seen the systemic vacancy rates start to fall pretty precipitously, particularly in the acute care sector. And the hope is that you know, as the demand for agency nurses goes down, maybe we're sort of seeing a trend toward, you know, a steady state, which is sort of back to pre-pandemic levels. Not suggesting that, you know, benign neglect is the way out of this by any stretch, but just wanted to point that out, that in Ontario, we're seeing some evidence that with systemic vacancy rates falling, maybe the agency hours will soon reduce.
I think the key word there is maybe.
Mhm. Yeah. Joan, I know that Trisha Lawson had her hand up, and then Kim has a comment in the chat as well.
Yeah. Thank you, Catherine. Wonderful presentation, Joan. And as coming from outside of nursing, really eye-opening to see this issue and how well you've presented it. I had two questions. One was related to just trying to understand for myself, like the ownership of the agencies. Like, are these Canadian owned, or are there corporations from outside of Canada who may run these agencies? And I was just curious about that.
I can't speak to that 100%, because again, we you know, when we first started this project, we actually we wanted to try to identify agencies based on websites. So I had my research team doing, you know, Google searches, and it was becoming so complicated because it's challenging. Some of them had a lot of information on their site, some had very little on their site. So I think that's, you know, it wasn't always obvious. I think the majority that we collected probably are in Canada, but I think there are some that are either international or US based.
Thank you.
Because some of them are large corporations, right? I mean, they have, some of them have multiple agencies under them. So whereas others are, you know, the local community agency that's providing home care in, you know, Moosonee, right? So it really was a wide variety.
Thank you.
And Joan, I just see Kim also. I don't know if Kim, if you want to say it probably more eloquently than if I could just read.
Fine. I wanted to say thanks, Joan. It was an amazing presentation. And when my mom was ill, I got to see a lot of agency nurses in the hospital and in the long-term care center. And, you know, I spoke with a lot of them, and they, you know, I said, is it hard to leave your country and come here? And they said they went into nursing to have money to support their families back at home. So it is kind of a conflict. We always talk about brain drain and not pulling from other countries, but sometimes people want to go to other countries to make the money to have money for their families. But when I donated, I just made a large donation of clothes and shoes to the long-term care center. And I said, please, if any of your residents can use these, like, feel free to share them. And they said, do you mind if we share them with the agency nurses? Because a lot of them have only come with the clothes on their backs. They don't have any clothes. And I worry, we've brought people to Canada and they might not have the right, weather, coats and boots and stuff. And it's just something that never was really on my radar until I had those conversations. And, of course I said, please share with whoever needs it. But, you just don't always have that on your radar as something you think about with people coming to get a better job, to get more money. You don't think about, I know they're housed in a lot of our hotels here, and a lot of people have brought their families over. I know probably 30 or 40 rooms in one of our hotels are all agency nurses in Kingston. And the other hotel has a large portion too. But I mean, I think, you know, if we need them, that's great. And they want to come, that's great. But I agree with you. It's not a sustainable system, but it was just that whole need of people coming here that I never really thought about. So it was an eye-opening experience. I was just sharing a comment. Thank you, Catherine.
Well, I think that speaks more to international nurses than just agency nurses, because not all agency nurses are internationally educated, right?
Yeah.
I mean, I think the majority aren't. They're nurses that were educated here and are moved from the public system into the private agency work. So
Yeah.
I think that can be true for any internationally educated nurse.
Yeah, it was just I just never thought of it before about people coming over and they wouldn't have anything to look after themselves here. So yeah, but thank you. Your report was great, Joan.
Thank you.
Thanks, Joan. I'm just looking at the time. I just must confess, I have one question I'm dying to ask you. I had a whole bunch actually, but patient safety, you alluded to this like around culture and training. Has there been any work, and I don't know if that was in your scoping review, that actually looked at like patient outcomes and like patient safety outcomes with regards to like facilities that had high use of agency nurses by any chance?
Yeah, that came up a fair bit in the international scoping review for sure. And the data, so I don't bring that a lot in. Well, I don't bring that at all in the report because there was so many other information that I could bring in. And it really, because I didn't bring it in because it's mixed. You know, there's some studies that have found differences, some that have found no differences, and I think it's complicated. And we tried it. You know, we did ask different groups about that topic, and again, it really varied, so it was hard to have a consistent response. So I think it depends on a lot of factors, and agency work might be part of that, but it may not be the only one. So, I know CIHI has put out results suggesting that the use of agencies led to increased adverse events. I think it's tricky, and a slippery slope to go down, because how can you say it's only because of the use of agencies and not because of other factors?
Yeah, no, that's a good point on all the cultural issues that you spoke about. I'm just conscious of the time. Just everyone probably has a 1 o'clock meeting they have to get to. Joan, I'm just so thrilled that you were able to present so hot off the presses from last week's publication. And we just put a few, there's lots if you want to hear Joan speak about this in other news forums. So Joan, thank you so much. So impressive, this work. And it really builds on your whole body of work looking at workforce issues. And thank you so much for having our first talk of the year. Great.
Great. Thank you.
Have a good rest of the day, everybody.